So I'm gonna go ahead and kick us off. Everybody, good afternoon. Thank you all so much for being here. I'm Christine Mallinson. I'm the director of the Center for Social Science Scholarship, and today we are convening our first ever virtual forum, so thank you for bearing with us. And we're gonna be discussing social science perspectives on the COVID-19 global health crisis. So before we begin, I just wanna take a very brief moment to address a couple of housekeeping issues. First, for folks who are joining us from Zoom, please keep yourselves muted, and I think I've got our settings set up so that will be the default. And then we'll be able to hear our panelists kick things off, and then you'll have the opportunity to unmute yourself to ask questions later during the Q&A. For those of you who are joining us on Facebook Live, you can type any questions that you might have as comments, and then we'll be able to share those with our panelists. And then please know that we're also currently recording our event, and afterwards we will upload it to our website, which is socialscience.umbc.edu. So onto the format of our event. We have 6 fantastic panelists joining us today. Each of them represent different social science departments at UMBC. I've asked each of them to speak for a couple of minutes about what key COVID-19 related issues they're seeing right now, and how insights from these folks' perspectives as social scientists can help us understand what's happening in the world right now. So in alphabetical order, let me introduce Professor Nicholas Bono in the Department of History. He's a historian of science and medicine, as well as a public historian. And he is currently teaching the course Global History of Pandemics. We also have Dr. Dana Bradley, who is the Dean of the Erickson School of Aging. She's a fellow of the Gerontological Society of America and one of the founders of the Global Aging Research Network. And her research has explored healthy aging and how to build age-friendly communities and institutions. We have Dr. Carissa Chia in the Department of Psychology. She is the lead researcher on a new National Science Foundation funded grant to study prejudice and discrimination against Chinese Americans due to COVID-19. We have Dr. Brian Gradski in the Department of Political Science. He researches disaster politics, human rights, democratization. He is also a first responder and a volunteer firefighter and an emergency medical technician. We have Dr. Zoey Mclaren in the School of Public Policy. She researches health policy and the economics of the global spread of HIV, AIDS, and tuberculosis. And finally, we have Dr. Lucy Wilson in the Department of Emergency Health Services. She is an infectious disease physician and the former chief of the Center for Surveillance, Infection, Prevention, and Outbreak Response at the Maryland Department of Health. So a very warm welcome to all of our panelists. And I'll go ahead and turn things over to them, and we'll just go in alphabetical order. So we'll start with Professor Bennett.
Okay, great. Hello, everybody. I've been lecturing in the history department here at UMBC for the past 2 years. I'm a historian of science, medicine, and environment, and my research focuses on the demographic and cultural legacies of infectious disease epidemics. This semester, I've been teaching the sadly well-timed course, as mentioned, A Global History of Pandemics, which we will be offering again this coming fall. Today, as a historian, I guess I just want to offer a few insights from our course discussions, discussions which began in our classroom on January 27th, where viewing the Johns Hopkins map, we first confronted the cluster of deaths around Wuhan, China, little knowing that the end of the semester would have us hiding from the same virus and discussing quarantine while practicing social distancing. So this class has given this experience has given our class a rare insight into this subject matter. So now, while it's dangerous to mix history and current events, under the guidance of, I hope, Cleo, the muse of history, if she's still out there, I'm going to present a few warnings and lessons from our class. So first, I think Cleo would warn us not to panic. Right? After all, pandemics are terrible, but they are natural phenomena, and as such, they've occurred with some regularity throughout recorded history. So while past actors may have seen portents of end times and plagues and pestilence, from Pharaonic Egypt and the Black Death to Spanish influenza and HIV/AIDS, the human race, as my students have learned, has adapted and survived. So life goes on one way or another, and we're not alone in our struggles. The second warning of Cleo contrasts with this first. While we've gained some perspective in my class from studying past pandemics, we've cautioned against fighting the last war. That seems to be a new lesson for us. Signs, for instance, plastered around 1918 Philadelphia warned spit spreads death, hoping that this intervention so effectively employed against tuberculosis might help against that new scourge. It did not. So lesson two, just as we criticize generals who prepare for the last war, our students recognize that societies often prepare for the last pandemic. Finally, Cleo's most persistent warning to our class unfolded as students came to appreciate the influence of social conditions on survival. We read of the Athenian Thucydides who bemoaned the abandonment of individuals who, after the loss of loved ones, were left alone to die in their houses. We discussed the slaughter of the Jewish community of Strasbourg on St. Valentine's Day, 1349, and the intensity by which hatred and ignorance led to the scapegoating of already marginalized groups. Seen against the backdrop of current events, these seem no longer the abstract evils of a faraway place and time, but for our students became uncomfortably close in motivation, if not in execution, to our current culture. In summation, what I've seen in teaching this pandemic is hope, humility, and an opportunity to empathize with individuals. If nothing else, it demonstrates the relevancy of studying the history of pandemics to the public. I think these should, and I certainly hope we can expand on these lessons from these well-caveated lessons from history.
Okay, great, thanks. We will turn to Dana Bradley.
Right. Yes, look at that. I was getting it's amazing. You know, we have been on these, this kind of environment now for a while, and I was sharing with the room. I've been actually on quarantine for 40, I think it's 46 days or 47. So I'm getting better, but it's amazing how much, right? All these signs. So a quick update from an exciting project that's coming through the Erickson School of Aging Studies, and then some thoughts. And I see there are a number of folks that have come in through the waiting room whose expertise is also in the field of aging and older adult, working with older adults in communities. So first piece is, and we're waiting on funding, so I want all of you to do this. Right. Thank you. It is right, because we're in this together. And this really is a theme about we're in this together. This particular grant proposal that we think is also, depending on what happens, right for an NSF quick rapid response one as well, has an international take. This involves 20 different countries. And we have been looking at how there's an evolving global media discourse about how communities can respond and assist, help or not, older adults during the COVID-19 crisis, right? So this is, if you are in the space of aging and older adults, it's a terrible time in that this is one of the most vulnerable communities across the globe. It's also wonderful because there's lots of data, and frankly, there's money to do research, right? So there's double message here, opportunities here. But we were approached by a colleague at the World Health Organization with the thought that we might be able to pull together this grant. And so joining with WHO and International Association of Gerontology as supporters, we put together a proposal that sort of melds several different themes within pandemic research and in aging and in disaster response. So for those of you in the room that are really experts in how communities respond to pandemics or disasters, and I know we'll hear more about that as we go through our panelists, there are a couple of different theoretical frames, but they often portray an emergency response to when bad things happen in a community. So if it's typically they might be physical change, a tornado, a a hurricane, right? So what happened with Katrina, for example. And so there's the time where things look really bad. There's an initial response. Let's say there's 5 stages. Some models have 6, some have 4, but we're tracking that across 20 different countries because we think that's a good model to look at, sort of that space-time continuum. And then we know already, based on social media reports, so not looking at what governments are doing or what NGOs are doing particularly, but what are we seeing in the social media about what you can do to help older adults weather this storm, if you will, right? That's a pretty apt metaphor. And what we're doing is we're tracking in these different countries the kind of innovative responses that we're seeing. So there's a metric for, how is innovative. But initially it's, and so we've got enough data in now, these older adults, particularly those in facilities, they're isolated, how poor, this is terrible. What can we do to assist and decrease isolation and loneliness with them, right? So lots of outpouring of concern, and this is really a time from a policy standpoint. There's actually, we think we will see innovation across countries, new things that could be tried perhaps. And so now we're sort of, depending on which country you're in and where the virus is, we can see this beginning to move toward the us versus them. So in the US, and it was about a week or 2 weeks earlier in Europe, it was the COVID-19 was called the boomer remover virus. You let that sink in for a minute. So that has a very different connotation about, how communities should respond. Because if it's maybe it's not such a bad thing, all these people over a certain age are getting sick and dying, right? So maybe it means a different kind of community response. So we're in the process of trying to track all that in a meaningful way that lays the groundwork for a lot of other research. And I'm excited because it's bringing attention globally to the role UMBC has across, as I reach out to all of you here in the room for ways as we begin to gather this data and then think about building upon this unique international collaboration. There are ways we can, I think, again, build on that and use that to strengthen research agendas across the campus. So it's really, for me, it's exciting. I've been here 1.5 years, and so I don't wish to have bad news. It's nice to have good news to see this as an opportunity. Okay, lessons learned so far. Older people are just like us. They just are older. And it is increasingly difficult for all of you, for our students, because of the things we talked about. There was an earlier town hall in research, right? Many of you, I think, were probably listening in. So often the research techniques we might use, and I'm going to look at Kevin Eckert because I can see him on the screen, and Nancy Kuzmal, who's also with us. But the kind of social science research techniques we often would use would be qualitative. And so figuring out, again, this kind of video can be done very effectively, I believe. The challenge is it requires sometimes an intermediary. If you're in a care facility, for example, and the staff, so one of the lessons, to kind of the wisdoms here is that it's always required community participation, collaboration, given the very, very acute circumstances of this virus. It is, even if we had permission and we're able to do these sort of video collection of data, the on-the-ground staff is overwhelmed, and that's not going to happen. I mean, some of you may be able to continue your research that way, but I think now and in the next few months, what I'm seeing internationally is that our collaborators within care homes, within institutions, even with NGOs are so overwhelmed they aren't able to be our partners. And that means thinking outside the box. I don't have any easy answers for that, but that's where I think some of us have gone to looking at external sources, social media, archival sources, even if they're relatively recent in terms of newspapers, that kind of thing. And I know there's a big movement to journal and dialogue during COVID-19, individual journaling, and that's Also, for those of you who use that kind of data, that could also be a very rich way to get an insight into experiences when this face-to-face interaction, and truly with older adults in their communities, I don't see that being very possible in the next short, maybe not so short while. For me, it's a time where I'm seeing so much misconceptions about aging come up in terms of public policy dialogue. You know, that just because someone's 60 doesn't mean they have a predisposition to diseases or dementia. Again, they're just like us. They're just a different chronological age. There are, of course, other things that happen across the life course, but I am seeing a far more, for me, it's an opportunity as someone who's a gerontologist to educate not only in the research, but to reframe about ageist messages. But I do see more of that visible discrimination than I normally would see, and that's a challenge, and a challenge for researchers, particularly younger student researchers, so emerging professionals who are not used to being in that teaching education role while they're doing research as well. But it's an exciting time, and I've been so grateful for our colleagues across campus that have been providing insight across all the colleges, not just you guys here, and then our colleagues in terms of different funding entities. So I'm going to stop, and again, thank you.
Great, thank you. Okay, Carissa Chia is next up.
Hi, I'm Carissa Chia. I'm a professor of psychology, and broadly speaking, my lab focuses on using mixed method approaches and interdisciplinary approaches to understand how individual characteristics, relationships, socialization agents, and culture and context interact to influence child and adolescent development across the lifespan. And so my research generally focuses on families from underrepresented backgrounds, so ethnic, racial, religious minority, immigrant, low-income background, both in the United States as well as internationally. And so we had an ongoing project for many years now working with Asian American families, predominantly Chinese and Korean American families in this region. And with this pandemic, so in the end of last year and the beginning of this year, we were starting to see, even within the families that we worked with, that the stress was high, but also reports both from families, but as well as through media feeds of increasing acts of racism and xenophobia targeting Chinese, Asian Americans during the outbreak and during this pandemic. And so what we're seeing is that this COVID-19 pandemic has really refueled historical and ongoing racist tropes that are really veiled under health-related fears. And we know, separately from a large body of research, that racial discrimination significantly decreases well-being and increases psychological distress and health and physical health problems among racial and ethnic minority adults and children. And so really the current COVID-19 pandemic has created a unique but urgent and we hope time-limited context to examine intensified discrimination targeting particular racial groups in the US, but really also internationally, that's overlaying an enduring context of chronic and systemic racism. And so what this particular research project that we were recently funded to conduct involves a group of an interdisciplinary team. So I'm a cultural developmental scientist. We have the other co-investigators include Dr. Shimei Pan, who's in the information systems department, who's a computer scientist who will be examining Twitter feeds during this period over the course of the year to provide a backdrop of how social media reflects the broader political, social, and event context and dialogue around COVID-19. and so that we can situate the experiences of the families in our research project. The other co-investigator is Professor Shishin Wang at University of Maryland, College Park, who's an educational psychologist, a school psychologist, and so who has studied bullying in the past. And so bringing together our expertise, we will be conducting surveys with families, both families who had participated in our studies before, so that we're able to examine increases in experiences of discrimination or not, and with ethnic identity for both parents and children, ethnic and racial identity, integration, mental health. We will also be conducting with a subgroup of these families interviews, so that we can really understand the lived experiences of these families as they're going through really an unprecedented historical event, how this plays out over the course of the year. And then, as I mentioned, the Twitter feeds to provide a larger, broader context. And so we really, sort of the overall purpose of this project is that although rare, infectious diseases will continue to emerge and reemerge globally, we know, and their negative impact on psychological health and well-being is really understudied, but highly significant. And so in particular for minority groups or marginalized groups that are linked to these diseases through social group categorization. And so we hope that the results from this study will significantly contribute to our understanding of both risk, but also importantly, resilience processes among parents and their children under conditions of an acute but prolonged social threat. And so we hope to also develop educational resources and also be able to inform educators, healthcare providers, and policy makers to really be more proactive in providing services and implement policies that can educate and promote well-being in both these marginalized groups, but as well as for the larger public during this current event, to be able to respond rapidly, but also in future similar events.
Great, thanks. Brian Gradski up next.
Great. Well, thank you very much. I'm a professor of political science, and most of my research has been focused on democratization and human rights. In the last several years, I've moved towards a more social justice approach, and that brought me into the disaster sphere. Christine mentioned that I have been a first responder for a bunch of years, for about 20 or so years with some breaks in between. Right now, I'm a first responder in Baltimore County. I was on a federal team, a disaster medical assistance team, for about 10 years. We responded down to Hurricane Irma. So I've seen the disaster system sort of inside out. And I wanted to talk a little bit. I do teach a class on disaster politics now. And I wanted to sort of give maybe my 2 cents, some sort of things to think about as we watch this disaster play out. And there are a couple of things that I've seen that really stand out. And first is, and they're interrelated. So first is America's, and not just the current president's, really tepid relationship with science and experience. And the second is a major structural deficiency in our disaster system. So I want to sort of just introduce these couple things to you. And again, in some ways, the two overlap. So I'll start with America's sort of what we'll call expertitis. We have a really long history of distrust towards experts, which is part of what brought Trump to power. And it's part of what led to such a slow response to COVID-19. If you look at opinion polling, there are large numbers of Americans who simply don't believe what the experts say. There are lots of psychological reasons for this. Various biases that make possible threats look unlikely to ever actually hit during our lifetime, and so we dismiss them. This has been manifested in remarks by the president, who's ridiculed experts as terrible, his quote, not mine, unnecessary, and really undermined science all the way up through the beginning of this pandemic. But it goes back. And you can just look at the large numbers who don't believe in things like vaccines in this country, who don't believe in climate change in this country. And it's worth noting that there is a partisan hue to this. Republicans are more likely to deny science and attack experts than are Democrats. But there's some that goes both directions. So our discounting of science really led to the denial of COVID-19 and its impact for precious weeks, and we all know that now. But when the government did begin to respond, we saw another problem. And this is the second one I referred to, which is with our disaster system. And in 2 words, I think we can summarize this as mismatched expectations. Really, state and local leaders have long operated under the expectation that the federal government, when times are rough, is going to come to their rescue in the event of a disaster. And the federal government has operated under the assumption that state and local actors are their own first responders, and national responders and any national response is just sort of a backup. And the outcome is what we call this classic moral hazard, where states who are comforted by this promise of outside assistance resist spending on mitigation. And they don't want to spend on preparedness. These are things that are expensive, and no one really gets credit for these things because they're really, for the most part, invisible. It's better to invest in a school than in preparedness. But the federal government, knowing that most disasters are local in scale, also has a very similar disincentive to invest. So there's underinvestment on both sides. And so now people have been talking for weeks about where is all the PPE, where are all the ventilators, and they are really, I think, victims of a broken disaster system. The caveat here is that the buck undoubtedly stops at the national level. So with the president, whose government is guilty of not just downplaying the COVID-19 threat, but also of failing to play even a limited backstopping role that federal leaders have relegated themselves to. And it's really a combination of these 2 factors, the sort of national dismissal of experts and the national government's pre-existing incentive to underinvest in disaster mitigation and preparedness that almost ensured the federal government's failure to be prepared by the time the cases of COVID-19 started multiplying around the country. So I think these are sort of central to understanding. And one final thought I'll throw out there is that hazards, and this has been brought up by other panelists, I think, in different ways, but hazards don't necessarily lead to disasters. Vulnerability, which is what transforms a hazard into a disaster, is socially constructed. It's how we ration health services. It's how we educate the public. It's how we provide sick leave. It's how we ensure nutrition. It's how we zone our land. All these things, socioeconomic status has a huge impact on these sorts of things. And it leads to certain people suffering more than others during and after a crisis and after a disaster. And so I'll stop right there.
Thank you. Okay, next up is Zoey Mclaren.
Hi, everybody. I'm Zoey Mclaren. I'm an associate professor at the School of Public Policy. I am trained in economics and public policy, and I've spent the last 10 years or so working on tuberculosis in South Africa, which is a deadly respiratory infectious disease that's transmitted by aerosol droplets, and we have very kind of poor quality data in general to design policy. So that experience gives me a little bit of insight into COVID-19. I'm going to talk a little bit about decision-making under uncertainty. So we have a lot of uncertainty with COVID-19. It's a novel virus. The countries that have more experience with the virus, like China, look very different in a lot of ways in the US. It's hard to identify cases because many people who are contagious have no symptoms. And the situation changes rapidly because of exponential growth. So our leaders at the global, national, state, and local levels making pretty critical policy decisions with very little information to guide them. So it's tempting for people to take a wait and see approach. So waiting until more information is available to guide the policy, but these delays are also potentially very costly. So there are 4 guidelines I put together for making smart decisions. The first thing is to look for decisions that are clear, even if all we know is the range of possible outcomes or the range of likely outcomes. And early on in the pandemic, we weren't sure what that was going to look like for the US. We knew the range was bad news. So we could have started mass production. So masks, we need them for healthcare workers. We may need them for the general population if we adopt universal mask wearing policies. And if we have a surplus, there are other countries that would be interested in buying those masks from us. Second, we want to make sure we reduce the likelihood of worst case scenarios. So COVID-19 spreads like invisible wildfire. So the shelter in place orders were one way to avoid the worst possible outcome and buy us more time to figure out a better way forward. Third, policymakers can take actions that are going to have positive ripple effects, also known as spillovers or externalities, or that can be repurposed in some way. So ramping up testing early in the pandemic is really helpful because it not only tells us about the current state of the pandemic, but it gives us data now to help us make better decisions and affect what will happen in the future. And fourth, We may only have access to biased or incomplete data, but that at least allows us to see some trends and also to look at potential best case scenarios, which are often bad enough to motivate policy action. So we're definitely undercounting COVID-19 deaths because of the limited availability of testing to confirm cases. But we can look at the trends because they tell us, are we still on a steep rising curve in terms of cases, or are we starting to plateau? So even in the face of an awful lot of uncertainty, there's pretty clear actions that can be taken, even very early in a pandemic, that buy us time for more analysis and will also ultimately reduce the financial and human toll of the pandemic.
Okay, and last but not least is Lucy Wilson.
Thanks for having me. I'm Lucy Wilson. I am a professor and graduate program director in the Department of Emergency Health Services. As you stated before, I'm an infectious disease trained physician and also a public health trained person. In my prior role, before I came to UMBC a year and a half ago, I was a public health officer for the state of Maryland, and I oversaw infectious disease surveillance, infection control in multiple settings, and also outbreak response for the state. And so as a medical epidemiologist, I worked through large-scale outbreaks in the state, including H1N1 influenza, Ebola, and Zika, and also predominantly focused descriptive epidemiology research and risk factor research in healthcare for healthcare-associated infections, and did a great deal of education and planning for healthcare-associated infections in nursing homes. So here at UMBC, I've been applying these perspectives on preparedness and response to pandemics and other natural disasters. So really, our motto is prepare, respond, mitigate, and recover. And so have been working over the last several weeks a lot in these phases of response and recovery and the many challenges within those phases. Now, of course, we're turning our focus to reopening, but as some of the other panelists have discussed, a lot of the preparedness to allow us to reopen hasn't really happened, such as adequate testing and enforcing the public health workforce so that we can do contact tracing, isolation, and quarantine and stop the spread. So as our country's surging forward to move into the phases of reopening, we're still behind the 8 ball on our original containment and mitigation planning, which is problematic. And our public health workforce at the local and state level has been reduced by almost 30% over the last 15 years. So when we're looking to surge, we're actually starting out at a real deficit from prior levels. So just wrap things up. In terms of research, I've been working with the Hilltop Institute and with the Imaging Research Center here at UMBC. And what we have been interested in, among other things, is the effect of COVID-19 on the continuum of healthcare. So looking at changes in outpatient, inpatient, EMS, emergency department, with respect to patient mix, service mix, especially focusing on telehealth and hospital surge, and really looking at gaps in care that may result and trying to look at outcomes over time from our response to COVID-19. So I'll stop there and really happy to be on the panel.
Great, thank you all so much. So at this point, you all can feel free, attendees, to unmute yourself and ask a question. You can also chat a question to me as the host, and I'll be able to ask it to our panelists. So I'll just pause, and folks can sort of feel free to chime in here. And I'm going to make sure that my settings are okay for you all to unmute yourself. Sorry, that might actually be part of the problem. While I'm doing that, I'm going to go ahead and ask a question to one of our panelists while I figure this out. And the question is for Nick. There's been a lot of talk about COVID-19 being a war, or how we need to wage war, or that this is our Pearl Harbor moment. Do you think historical metaphors of war are useful in this case? And sort of to what extent do you think that metaphor might be useful or not useful.
In terms of medical responses, they've been fairly useful. We have some good examples. For instance, the eradication of smallpox, the utilization of polio vaccines. There seemed to be a sort of rallying the troops moment around that. But there's just as many, if not more, examples of the misuse of that. I think one of a particularly interesting example is that of cholera. Not to go too far back, but cholera first, the illness that we recognize as sort of cholera today, what was Asiatic cholera at the time, the naming is somewhat problematic in and of itself, began around 1817, 1818, and much of the world was watching that spread move out of the subcontinent, and it eventually, by the time we got to the 1820s, news media around the world was seeing this as sort of a spread of Asia moving west into Europe. At the same time that Russia was preparing for invasions of Poland, and there was this worry that somehow this virus and this very real threat to many of a Russian empire were sort of becoming one. And you got this through news media, even before, we're talking, 14 years before its arrival in the United States. You had newspapers all across the continent, even in places like Arkansas, running articles like, here comes this wave, here's the enemy is coming to our shores, like we need to prepare. And it's lasted to this day. We think of cholera as the typical 19th century disease when, as pointed out, tuberculosis killed far more people, right? But we think of cholera as that because of the media attention, because of this call to arms against this. Sadly, I think it didn't really do any good, as we can imagine. So there's been times, and of course, sort of as a post note to that, the association between disease and war is probably as old as both. And, we do have the best example is the Spanish influenza as one, but, recognizing that for instance, more troops died in the Civil War of disease than died of and infectious diseases and epidemic scales, where it's a very dangerous it's a very dangerous association to make, I'd say. But we don't, we got rid of smallpox.
Thank you so much. We had another question come in on chat. What are the long-term effects of COVID-19 on voting issues? So Brian, maybe you want to take that. Oh, you're muted, sorry. Sorry, Brian, hang on, you're muted. I'll see if I can unmute you on my end. There we go. Now we can hear you. Go ahead, sorry.
Okay. So I guess as a political scientist in the room, I should take that. But I think that there's, honestly, we don't know. We don't know what's going to happen. There's resistance on some sides to mail-in ballots. There's a whole question of what's going to happen at the Democratic convention in the summer, and we honestly don't have the answers. So I can make up a bunch of stuff, but I don't think it would be very genuine, so I'm not going to. But it's a huge question. How do you, look at Wisconsin? Do you want people to go out there and be next to each other and stand in line to vote? Would I go vote? I don't know. If my safety's on the line, maybe not. So, a good question. Sorry for no answer.
Thank you. Another question that I think is a great one is how might social media be hurting and or supporting the response to COVID-19? So I'll say Lucy and Zoe might be good to answer that one.
Sure, I can start. Social media is certainly a very popular and predominant way to get information out. And a lot of information has been shared, and information has been shared from communities who might not otherwise have a voice in educating and spreading information. But of course, there's the other side of social media where misinformation and bias can spread widely. So it is a mixed bag, but it is here, and it is a very predominant way of communicating. And I'll let Zoe add.
Sure. Social media is very powerful, so it goes both ways, that it's good at spreading good information, but it's also really good at spreading bad information. And I think one of the big concerns, and one of the things that I'm seeing, I'm on Twitter, is that every time there's a little bit of new information, people are desperate for information. In the face of uncertainty, people get very stressed out. So they're going to be kind of grasping for whatever kind of information makes them feel more secure, gives them some kind of certainty. When people are stressed, the part of their brain that helps them think logically is impaired in some way. So people who are stressed are not going to be processing the type of information that comes in through social media quite as well as people who are less stressed. And so I think it's, like I said, it cuts both ways, but that things move a lot more quickly online because of people's stress level, because of so much uncertainty, people looking to resolve that. So I think there's not much that we can do, but minimizing misinformation online is a really, really important thing we need to do right now.
Just to back up what Brian Gradski had said, some of this desperation for information comes from a distrust of experts. And so looking for information to back up or disprove the information that is coming out.
Thank you. Kevin Eckert, I didn't know if you had a question that you wanted to ask?
Yes. For those of us who collect primary data through face-to-face interviews and such, to kind of examine the lived experience of various things, I would be interested in any suggestions from the panel or anyone else on how we might approach people in this particular environment, understanding that some of the people we might want to approach, social media is probably not going to be accessible and available. So any ideas are welcome.
This is Dana, and I'm looking on my, I can see all your panel. I'm looking down at Nancy Guzmal, but I'm wondering, Kevin, I'd mentioned in my earlier remarks how challenging it is. Normally, if I was looking for interviewees, I would, I might go through some kind of intermediary, like we're older adults, and I'm going to go with older adults, right? So that would be, or the families. I might go through a service organ, an NGO, maybe a government entity where they're living. It would be, I wouldn't just, and I've done this, I've actually been in a supermarket trying to find people, right? But there's a process, right? And it usually, so it requires a relationship of some sort and that trust. And that's still all, the hallmarks of doing, I think we'd all agree, hallmarks of gathering participants if you're going that route. But here we've got this physical distance between us now, right? So I hate the term social distancing because that's really not what's going on. And so we did put a call out in the Gerontological Society of America, a couple of our Connect, the BSS actually, through one of those sections to sort of ask. And one of the things I was, if you can approach, I was trying to figure out, the whole idea of talking through glass, right? So that doesn't mean you still have to be able to approach, to connect, to have permission. But the face-to-face, that distance, there's still the 6 feet or your glass. We see people conversing using signs and playing their instruments outside someone's window. There's very evocative images on social media that shows at least attempt to connect. I haven't seen anyone using any of those in a research setting yet. And so that's why I was tipping my head down to Nancy, anyone else, because it's really, we've got diaries, we've got archives, we've gotten the written that I think are being accumulated that will be very useful. but it's again that the being in the moment.
So in our project, we are doing both surveys, but also interviews. And so we've reached out to families by calling and speaking with them and trying to establish rapport in there. But we have had surprisingly not a lot of resistance with regard to people wanting to talk about their experiences. And I think that can't be overlooked during this period. So while families are extremely stressed and their schedules are disrupted by everything that's going on, and especially the families we work with have children of varying ages, but we found that families want to talk to us, and so and we have been giving them the option of doing it either through WebEx, so IRB recommends WebEx because of security, but then also for some families, as you can imagine, who might not have access to either a smartphone or a computer, we've also gone the route of doing interviews over the phone instead of recording it that way, and that has not seemed to be a problem so far.
So I have a couple questions that are on a similar theme for Dr. Chia while she's on the mic. The questions are basically about why do we think the virus is being talked about in terms of being a racial virus? What sort of political tensions do we think that might stir up? But then also, are you going to look in your research into factors that might mediate sort of the negative effects of racialization and how to build resilience among these communities?
Yeah, so unfortunately, the practice of racialization of pandemics is not a new thing. It has a very long history, as many of the folks on this panel and in our audience knows. And from a psychological perspective, it ranges anywhere from sort of fear, a threat to a certain lifestyle that may stem from actual fear of health concerns, but then comes to maybe broaden to a fear of a threat towards a sort of particular lifestyle that someone else, a foreign other that has a different lifestyle might bring with them. And so unfortunately, this is not a new thing, but I have to say that from psychologists have not done a very good job thus far really documenting it, whereas other social scientists have. With regard to what's been happening politically, absolutely. So President Trump's use of terms like the Wuhan virus or the China virus has stirred up additional sort of anti-Asian sentiments, anti-Asian American sentiments. There was a recent study that was released that actually did track some Twitter and 4chan data, and then actually showed spikes at the points in time in which this was going, when he used these terminology that were a greater use of racist and racialized terms and xenophobic terms in these social media forums, and it peaked over this time. In general, it's going up. So, I think that we can safely say that there are some consequences, to that. And therefore, again, from a psychological perspective, while, some people may justify the use of these terms with regard to, the Chinese government or the geographical source, even the World Health Organization has come out to say, don't, recommended against using particular, sort of regional or geographical terms to be associated with, viruses, because we see these effects on the societal level with regard to the association between a group of people and a fear that, again, can be generalized and can provide a mechanism for individuals to perhaps engage in acts of racism that they might be less easily available to them, previously. And so while, your anger or frustration may be at the Chinese government, but, you have as an everyday citizen, may not have access to that government. And so you may have access to an individual who lives in your neighborhood who looks as if they might be Asian. And so therefore, hence it is a sort of danger with that. And it also, I think, creates difficulties on other levels with regard to, obviously, the stigmatized groups' vulnerability during these pandemics, and so fear of seeking medical help, if in order to avoid discrimination. And also, I think it takes away attention and limited resources from just the general public with regard to what are things that we can actually do to help us be safer during this period, right? We're all stressed. We're all, working under, a very resource limited period right now. And so I think that we all obviously, sort of share the responsibility for good public health practice that involves, appropriate social distancing, washing our hands, but also embracing and valuing, diverse people and communities and looking out for each other. And, the use of these kinds of terminology really take away our attention and take away our resources from, as I mentioned, what are things that can really help.
Can I just chime in here? I wanted to mention, we've seen in past epidemics, like if you look at the cholera epidemics in Europe in the 1800s, it's not just racism. So far, we've seen racism and ethnic discrimination because of this, in part. But we saw classism back then. It's the poor people, and these are still the same vulnerable populations today. And yeah, so at a lower socioeconomic status, you're more likely to maybe get the disease because you're stuck going to Giant and working or whatever it is. So you're out in the community. We've also, and this is a little bit different, we've seen attacks on medical workers. We've seen this already in several countries to date, but we saw it during the Ebola crisis in Western Africa. And so these sorts of, these vulnerabilities go across just racial lines, although we've already seen it racialized.
Thank you so much. And I think we had Nancy who wanted to respond to Dana and Kevin from before.
So I've been sitting here kind of thinking about your discussion about finding participants and recruiting for the kind of research that I know you do, Kevin, with the in-depth interviews. And I think that it's an interesting time for that, especially when you're talking about older adults, when we're talking about the social distancing and people maybe having more loneliness and isolation. They might really be interested in talking and participating in an interview about their experiences. And I'm thinking, not that I've tried any of these things, but I'm thinking about, through caregiver groups and then snowball sampling kinds of techniques. It might be a good time to have some of those conversations with older adults who might be isolated, who might be interested in talking and sharing through a research process. Kevin, you're muted. If you're responding, oh, there you go.
Am I unmuted?
Yeah.
Thank you, Nancy. One of a colleague, Laura Gerling, is doing work on older individuals who have mild dementia who are living alone. And I think she's trying to pursue a supplement to talk about their circumstances under the current conditions. So I think that's a good example of, for me, I think, and thank you for your comment, because it's how do you develop a sample of participants at this point if you don't already have one? And that's what I'm finding the challenge is we can't really go back to participants in some previous studies, for example, a diabetes studies of low-income people in Baltimore. We really can't go back to those folks for various reasons. So it's how to develop a new group of participants is the key, especially the people who are most vulnerable. And also, it's the age of isms, and I think ageism is certainly one of the big things that's really come out in this whole pandemic issue.
Yeah, that's a great point. I also wanted to give Nick a chance to respond to a point from before as well.
Yes, thanks, Brian, for bringing up the cholera years. But I think there's a point that could be made to follow up that when we were looking at the isolation and the scapegoating of the poor in 19th century Europe and in the United States, we're working under a different understanding of what disease was. The sanitation idea of disease, the hygiene idea of disease was there. And this is not to countermand Brian's point at all, but to rather underline it. This came from thinkers like Thomas Malthus, like Edwin Chadwick and his famous Poor Laws, where there was a belief, whether we want to buy into the authenticity of that belief or not, come and take a class with me sometime, but there's a belief that it was part of being poor, part of living in filthy conditions was the actual cause of disease. And that while germ theory has pushed that aside on a medical level and on a policy level, even with the great examples of folks like typhoid Mary Mallon that have caused their own troubles in terms of implementation, and speak to our problem with experts, there's a legacy of that idea that persists. There's the McCowan thesis for those of us who are interested in demography and policy, but this goes all the way to Reaganomics and into the sort of neoliberalism that we're seeing today, that when we have a breakthrough where we understand germ theory, we've never really taken the time as a society to wipe out old ideas. We tend to bring this sort of relativism along with us, and we're so afraid to say this is wrong, this is right, and then demonstrate that to students. And it's a very frightening idea, I think, for us as educators to say, I'm sorry, but everything you think is wrong. And we need to wipe that away and give you this new set of ideas which are correct. We want to have humility. We want to, give everybody a chance to speak. But I often wonder, especially as a historian, where we want to give the perspectives of people in the past and we want to think in actors' categories, is there at some point where we just have to say, enough is enough, this came from this, we're no longer thinking this, here's the history of why these ideas seemed okay, and at the risk of vilifying people who adhere to those ideas today, like our president, how do we make those corrections, and how do we stand up and speak truth to power, so that ideas like the association of cholera with the poor don't persist and take money away from folks that were dying of it in Haiti so recently, among so many other examples. So that's my 2 cents.
That's great. We're getting so many great questions, and we're not going to be able to take all of them, but I've got 2 questions that are pretty similar, so I'll just sort of pose them as one mutual question. Is there a body of social science research that talks about how to either anticipate or predict or change the public's reaction to things like pandemic? So how, in other words, can we address culturally mediated beliefs? How can we sort of address that interface between politics and policy in a way that might impact health outcomes? So if anybody wants me to call on you, I was wondering if maybe Zoe might want to chime in on how to sort of bridge that gap between policy and individual practices.
That's a really tough question. And I think one of the big challenges in dealing with this pandemic is that we have never dealt with a pandemic like this before. So that is really hard to know. And I think a lot of the conversations about policy are based on models. They don't take into account how information spreads, how people learn, how people gather their own personal information, make sense of all the evidence that's out there. So it's, I think, a really hard question to answer. And I think the only thing that we can really do is just recognize that we don't know the answer. And so in terms of our policies, we want to make sure we design policies that will allow us to allow for kind of a learning process, allow us to collect data, allow to test the waters. And I can just give one example, which is the kind of the question of whether do we wait to open, kind of reopen, remove the shelter in place until we're certain that we never need to put them back in place again? Or do we plan to have, not necessarily planned timing of them, but them as a fail-safe? So kind of saying that we'll try to open back up and we're going to learn how people respond, learn how the public health messaging translates into individual actions, and then also learn how those individual actions translate into health outcomes. We don't know the relationship between we know that being shelter in place is going to reduce the spread of COVID-19 by quite a lot. So we can see kind of how well that worked. We don't know kind of which policies loosening them by how much and how to explain to people about what they should continue doing and how to be cautious. We don't know how that's going to translate into deaths. And so I think we need to make sure that we build in a learning process. And the things that I've been thinking and writing about involve letting individuals know that there is a learning process and they're part of that. People kind of ask, like, what will the models tell us about the future? And it's like, no, that you're kind of co-creating the future, that your behavior and the behavior in your community is determining what's going to happen. And so you can't just trust the models, like everything's going to be fine, and then go off and do things that are really risky. So I think that process of, this is like decision making under uncertainty. With policy, we like to eliminate the uncertainty so we can make policies that kind of provide individuals and constituents with a level of certainty. But I think in situations like this, it's much more, and people want to do that to maintain the credibility. But I think with so much uncertainty, you're going to lose credibility if you try to say that you're sure about what's going to happen. Mm-hmm. And so kind of designing policies in a way that allow for policymakers to learn, for citizens to learn, and for the communication around kind of the uncertainty, I think maintains credibility. And there is some certainty in uncertainty. If we know that there's a fail-safe, for example, that we have to go back into shelter in place if we hit a certain threshold, that provides us with some certainty. If we have information to kind of tell people how we're doing relative to that threshold, that provides some level of certainty in the face of uncertainty. So I think that that's one of those tricky things, is we're learning as we go, and there's just uncertainty that can't be resolved. And we need to be learning, and we need to kind of communicate as policymakers that we're learning, and that doesn't mean we're doing things wrong, or that like there's ways to know it and that we're not using. It's just that a lot of the parameters are really unknown. We're in uncharted territory, and do policymaking in that way.
That's great. Anybody else want to chime in on that? Yeah, Brian.
So I would just add, yeah, everyone hears me? Yeah, okay. I would just add, and I agree that this was sort of, it's unknown in a lot of ways how to deal with this. There's actually a paper that I've been meaning to update. It's from 2005 by Osterholm, who was talking about the coming pandemic and how we need to get ready because everyone knows this is going to come, right? So it's that known unknown. And people have largely ignored things like this, even though everybody's pretty confident there's going to be a pandemic. We've already had lots of warnings. We had H1N1, we had, SARS, and all this stuff has already floated through. It just hasn't reached the sort of level that we've hit. And I think a lot of the reason for this is just because of the way our institutions are designed. We've got politicians with short time horizons who are going to gain nothing from investing in this sort of thing. And so that's a barrier that we're still going to have as we move forward. And the public doesn't like to invest in these things, right? Why invest in something that might happen, but we don't know if it's going to happen, and it might happen in 100 years. And then add to that the idea of vulnerability that we've talked about. And if it does happen, it's probably not going to hit me, right? Lots of people feel that way. So the one thing that I wanted to add here is that there is a bright spot, which is that after a major disaster like this, it tends to be that little sliver of light when policymakers open their eyes, when organizations that are already existing can come up and they can say, hey, we've got some ideas that we've been trying to tell you for a very long time that can help deal with this in the future. These are what we call focusing events. And so this, there's no doubt that this should serve as a focusing event. The problem with that is that there's a very limited window of time in which you can operate before the public gets back to its regular place after most disasters. Now, this disaster may be totally different, but usually there's a very short window of time after which the public walks away and they don't want to focus on this focusing event anymore, and policy goes out the window.
Thank you so much. So I know we're already a little bit over time. I just wanted to give the last 2 minutes to Lucy Wilson, who I'm hoping can answer the question. As a physician, how do you think we can best support the medical personnel and health professionals who are at the forefront of the response to COVID-19 right now?
Okay, well, I have a lot of thoughts on that, but but in an urgent way, we can provide them with personal protective equipment. We can provide them with testing for active infection. We can make available to them antibody testing or serologic testing to see whether they have immunity of some sort at this time. We can offer them shelter so they do not have to worry about infecting their families. We can offer them adequate equipment and medication, sick leave, hazard pay. We can support healthcare workers in terms of malpractice coverage, which has been actually an issue for this pandemic, and prioritize them for vaccinations.
All right. Well, thank you all so much. We have so much more that we could talk about, but we're going to let everybody go since we're a little bit over time. Thank you so much for coming. And again, we will be posting the recording of this event on our website, socialscience.umbc.edu, for anyone who might want to refer back to it later. So thank you all so much for coming.
Thanks.